Good evening, hello, and welcome to yet another podcast on the Gyan Pravah. It's indeed my proud privilege today to welcome our dear Dr. Sunita Tandulwadkar, who is the president of the Federation of Obs and Gynecological Societies of India for the year 2025. In the field of obs and gynae, who does not know our dear Dr. Sunita? She is the brainchild behind this Gyan Pravah and is a source of talent and inspiration to many young and old gynecologists across the country. She has taken the department, the obs and gynae specialty to a next field. And I think today is a day of pleasure and honor when we're going to have another celebrated gynecologist on our podcast. So today, to set the ball rolling for this podcast on one-stop assessment of hurdles to parenthood, I take the pleasure of honoring my speaker, Dr. Karnakar, and I would request Dr. Sunita to take it forward and introduce him.
Nina, thank you so much. First of all, welcome, sir. It's honor to have you on our Fogsi platform, Gyan Pravah. I'm sure this podcast will be not only interesting, but it will be a huge learning to even to the expert one, because the tips what you will be sharing, how to simplify or how to do it, probably everyone will carry home certain important messages. And Nina will always do it in a very elegant way. I know how she will squeeze out the answers to the benefit of our Foxy society. Now, this Gyan Pravah is our podcast series. I think today is the 13th episode, and every evening, 8 p.m., we are having our team of committee chairperson. If Nina is on 10th, every month on 10th, you will have Nina Malhotra with one of the national, international faculty, academic, non-academic, from social background, from a spiritual background. She's from Delhi. She can have a lot of politicians coming in also. What is important is we try to have a dialogue with one personality, with one topic, so that in 40 minutes, we can come out with a very good podcast, which is educative or informative to everyone, even those who are not Foxian. This podcast goes on a social media. So we have international login. I think maybe with my 100 podcasts, I believe that all the country societies will start logging in. And sir, we will give you the link, and please make it to your country as well. Thank you so much for giving your valuable time to Foxy. And probably I will hear everything from the different link. Thank you, Nina.
Thank you, Sunita. So before we set the ball rolling, I think let's introduce a little bit on the topic. Infertility affects 1 in 6 couples. These are estimates which come from the World Health Organization in 2023, i.e., about 16 to 17% of couples across the globe are suffering from subfertility or infertility at a given point in time. So much so is the problem that WHO has now accepted it as a disease. The social, emotional, psychological, and of course the financial trauma of this disease is humongous. What about data from India? If we look at the national health surveys, the data is rather dismal. But if we look at the estimates that we get from the IVF industry or the healthcare industry, it is recognized and appreciated that about 20 to 25 million couples suffer from infertility in India, out of which just 40 to 50% of them seek medical help. To understand the problem, I think we know that these couples go for their treatments from one clinic to other, make multiple visits, and this further adds to their emotional trauma. To deliberate on the subject of one-stop assessment to infertility or hurdles to parenthood, I have a very celebrated clinician, Dr. Karunakar Makranti, who's had the privilege to be trained at some of the best centers across the globe. Having had his initial training in obstetrics and gynecology at the prestigious All India Institute of Medical Sciences, New Delhi, Dr. Karunakar moved to the UK, worked at the famous Bonehole Clinic, which gave the birth to the first IVF baby of the world, Louis Brown, and had worked in many centers across London, Cambridge, and after 15 years of stint, he's shifted his base today to Dubai. Welcome, Dr. Karnakar, to this show. I'm sure
Lovely
you.
meeting you, sir. Thank you so much. And I will enjoy the dialogue between you and Nina. Thank you.
Thank you, Sunita. Thank you so much for joining. So, with over 3 decades experience across working different continents, we have Dr. Karnakar who will deliberate on this subject. So, Dr. Karnakar, as I see that there is a rising trend of infertility across the globe in both developed and developing world, what are your views on this rise in infertility? Do you really see a rise in the 3 decades or 30 years that you've been practicing this specialty of reproductive medicine and infertility?
Thank you for the opportunity. Thank you to the listeners. Without listeners, there is no speaker. Without patient, there is no doctor. There is no student, and there isn't ever a teacher. So I feel honored to talk to the audience and the organizers who gave the opportunity. The answer to the question that is more women suffering childlessness is a combination of more awareness with the people that there is a help available if they're getting stuck, and also the lifestyle significantly has affected both men and women and their ability to be together, what the ancestors has done. So the lifestyles have changed so much. We are not doing what our great-grandparents did, being together, eating well, and sleeping together. A lot of changes. So it's a combination of human factor as well as the more awareness that the people are reporting infertility. Otherwise, they used to silently suffer infertility in the past. There was no facilities. There was no IVF. Most doctors, there was no subspecialty of reproductive medicine. So I would say it's a combination that, yes, more people are suffering infertility. I can give some examples, but more facilities are available in the media that they know. They talk to their friends and friends will guide them to infertility specialist. And the media is also helping people to seek help. So it's a multifactorial reason why there is more appearance of infertility on the media as well as in the reality. So just a simple example, in France, the male infertility has increased, or the sperm became worse by 33% in the last 17 years. So we are heading in the direction of natural conception is going to be harder and harder every decade goes by because our lifestyle compromises our gamete efficiency.
So rightly said, I think it's increased awareness, increased acceptance of the problem, and of course, I think we've got better medical facilities. Do you think the changing social norms and the changing lifestyle have also had a bearing? And how do you see that couples who are struggling to have babies, do they sort of, do you think that the increasing stress in today's day and age also is adding up to this problem?
Stress seems to be a word which is spoken. Every second word spoken, even in the schools, is called stress. People see things are not happening the way they want, and things they don't want is happening to them. So that is, it's starting even in the school. The word stress is growing like cancer. So therefore, stress means hypothalamus is affected. Hypothalamus is the great-grandfather or the biggest boss of human body. Once that is affected with stress, it will switch off reproductive function or it will compromise reproductive function. The last thing people want when things are not going the way they want is producing kids. So reproductive function gets affected directly and heavily and significantly and chronically by stress. So yes, stress is affecting significant proportion of people reporting or that, and also they don't embrace the treatment because of stress. And the financial costing of fertility tests and treatment is also adds to this. So it's a vicious cycle of stress at every link in the entire loop of reporting infertility, suffering infertility, and then seeking help and the success. Everything is affected, and it affects metabolism, weight, sexual function. So their direct impact is very significant.
I think you rightly said stress is there at every point, every day. And I think we see not as the stress adding to the problem, but I think once they fail to conceive, it further gets aggravated. And I think it's truly a vicious cycle. So I do see that when we get couples, they have visited us or they're visiting Dr. Karnakar, they've gone through a series of, clinics, they're changing doctors. And then, I think multiple visits, long wait lists to get appointments is another kind of problem that adds to their woes and, of course, to the emotional trauma. So, do you think, Dr. Karnakar, that in some way can we ease out? Can we have means so that we give them a kind of opportunity, or maybe let's say an initial approach, which is kind of not just looking at their problem from the doctor's view, but a holistic kind of an approach when they come to you? How do you sort of see that? Can you sort of give one-stop solution for their assessment? Do you have, I mean, you've got so much of experience. How do you foresee and how would you like to take the couple coming to you for, for a holistic assessment under one roof?
Yeah. So if anybody is accessing the computer and they type the word one-stop fertility assessment, you get around 35 links in first page and it goes through the next page links. So this has been a popular concept in Europe where a couple, either they want to be parents, they can come for fertility assessment, or they already tried and then they found themselves to be infertile and they come for infertility assessment. So either way, one-stop fertility assessment, who are interested to be parenthood, or people who already tried to parenthood but they failed. So it's called one-stop infertility assessment. Both can come with a single visit, usually within an hour. We can identify the couple's ability to create life, accommodate a baby, feed a baby is in the good category or below average category, or very, very poor medical information that they have or medical situation they have. So we can, in a single visit, lasting for 60 minutes, both couple coming in a single visit, we can assist whether they're in the green category, amber category, red. Red means no matter which country they go, how many IVFs they do, whatever technology, AI, you can put anything into place, their success rate is less than 5%. If it is a green category, with small help, medium help, or advanced help, we can make 80 to 90% of people achieve pregnancy. Even by talking and doing the right advice, people do get pregnant even after your consultation. I'm sure you come across that. On the month that just take them for infertility consultation, they get pregnant and they admire you for that because they just spoke to you, they fall pregnant. So there is a green profile people, 80 to 90% of them can be assisted. There are red profile. Unfortunately, science cannot help 8 out of or 9 out of 10 times. So we can appraise them of their medical situation dictates the success.
Yeah, brilliant. I wish we all had a magic wand, so that all of our patients could fall into the green category. Perhaps we would be the happiest as clinicians when they come to us.
So
So,
98% of the children are born without seeing any doctor. They are the green category couple. So we are virtuously fertile when we are born. 85% of us are fertile. So the nature is always brings good things out and it eliminates the unfit. We all know the most unfit embryos are eliminated as a miscarriage. And therefore, so the fact that your couple came to that, 85% of them don't need to see any doctor to cherish the parenthood. So nature is far more superior curator than clinicians.
So thank you so much, in the way that you've kind of started this journey with a couple, when you sort of given us such a beautiful insight and you were opening doors to this couple. When they come to you for this 1 hour, how do you sort of look at it? You just kind of assess the couple for their medical side, or you think there is, because there's stress, look at the other aspects, their social backgrounds, or how do you sort of take them in this journey of parenting as they sit with you for an hour? How would you throw some light on the way you approach a couple, so that we could get more wiser, and maybe the audience who's watching and hearing us would be a lot of our patients who would sort of like to know what would be your approach and how do you see this?
Yeah, it's not in disease. They don't wait for people to suffer the infertility. So they educate schoolgirls. What is normal fertility? What is subfertility in the school? It's a school health education. Then we have young women's clinic in most parts of Europe. So young women means they just understand why they have menses. Menses is nothing but cleaning unused baby food every month. It's very simple way of saying. So this is the living room and the food is grown in the center. Every month, every woman waits to invite a baby. And if the baby doesn't come, they just clean unwanted baby food they made. So people are taught what is menstruation from the time the menstruation charts, what is fertility, how to prevent unwanted fertility, and how to identify when the fertility is damaged at various age groups. So these are called preventive healthcare program or health clinics. So in countries where such public health foundation investment is there from central and state governments, so people are being educated. Yes, your fertility is okay. Next 5 years, you can wait. And whenever you want to conceive, you can, try naturally. And then if needed, you can take help. So if the system is not like that, then they become patients. The system that different countries, to give an example, we call even a large group of people, or we can give a common meeting to couple who are struggling. We explain to them reasons why people are slow to conceive. Then we tell, basically, it's an ultrasound test. It's done in 5 minutes. Just do an ultrasound scan. It's fairly safe and easy. It's painless. And this is where what we can see. This is the living room for the baby. And this is where the eggs are stored. It takes 1 minute to assess women's ability to create the babies in the green zone or amber zone or red zone, the potentiality to create life within 1 minute of scanning with an ultrasound, which is painless. And women's ability to accommodate and to feed a baby is good or average or below average or very pretty badly damaged can be assessed within next 2-3 minutes. So if the woman has anything against her fertility, it can be assessed within 2-3 minutes of ultrasound. So it's basically the female is assessed with a blood test and a scan, which takes few minutes. After have taken the history, how long they have struggled, any previous surgeries, previous infections, anything that gives us a hint to say that how bad their infertility has been, will give us the background, and then 5 to 10 minutes of assessment and a blood test, which takes 3 hours to get the report. And that gives an idea of the female. And also these days, within a single visit, we can check the egg and sperm meeting place. We call them fallopian tube. They're working or not with the same ultrasound within 5 minutes. Again, it's a mild pain or mild discomfort. So the ability to create life, ability for the egg and sperm to meet in the place where we call the wedding hall or fallopian tube is working properly. And also when the baby is formed and where it comes and stays for 9 months, the living room and the food is in the green category, amber or red category. All this can be assessed in a single visit, less than 10 minutes of scanning or 15 minutes. Where things are wrong, we can use something called endoscope, again in the same one-stop assessment to check and sometimes see and treat things which are stopping the hurdles to their conception. So we call them one-stop infertility assessment service in female, one-stop miscarriage assessment service, and one-stop infertility assessment service. Literally 1 hour having taken history. Coming to the male, once again, he can send the pictures of his genitalia and do a blood test, and we can confirm whether he's manufacturing sperm and it's a healthy or not, whether he's manufacturing but is unable to transport or not due to sexual dysfunction. That can be analyzed with history and examination with ultrasound and clinical examination, 15 to 20 minutes. A blood test will tell 90% chance he can father the child with his own gametes, or he need to depend on elsewhere to become parenthood. So literally one-stop male, one-stop female assessment, all can be combined within an hour. It reduces the heartache of people going for once for blood test, another for hormone, another for ultrasound, then the ultrasound report, then the second follow-up consultation. So all this can be married into one-stop fertility assessment or infertility assessment. It's been in practice for nearly 20 years in most places, and it's extremely well accepted by couple. It reduces the cost very heavily, and it gives them the clarity within the least possible visits. If it is red category, they accept. Most of the patients don't see us as creators or gods. They see us as good farmers. If the plant is strong and the soil is strong, the crop is going to be 98% guaranteed. Farmers don't do PhD to grow the crop. And so making babies nothing akin to making crop.
So that's fantastic way of, kind of putting things for patients, for doctors, for healthcare providers. So we see that we are just not giving a diagnosis to the couple's problem. We're not just finding answers to this diagnosis by helping finding. I think we are working on predictive models where we can predict. Thank you so much for giving this idea. Now, since you've been talking about the one stop and we're talking, I think we do get patients getting exhausted with not just one, too many bloods. I just wanted, can you dwell and let us know what do you understand about this one-stop assessment? What bloods do you think are making some sense, because I see patients coming with heaps of papers, heaps of, blood tests. Somewhere can we simplify? Can you sort of give us some idea to which would be the best, test that can assess and help her, let us know whether she's in the amber, green, or the red zones?
Ultrasound, ultrasound, ultrasound. So properly trained doctor with theoretical knowledge and practical knowledge and empathy to the patient, and the machine equipment quality is good, he can make wonders with ultrasound. So I put ultrasound as the top of that. Once a doctor can access the ovaries and count the number of follicles or the egg bags, I call them egg bags. Nobody can see the egg. I just want to educate the audience. No one with ultrasound can see an egg. And they can see the egg bag or follicles. So you can see the grapes. Tell the patient you are seeing grapes, but some grapes are seedless, and without seed, you cannot make a baby. So please tell patients, we can see the follicles, we can never see the egg. A lot of patients are coming to say us, my eggs are good, I'm not getting pregnant. My tube is good, I'm not getting pregnant. My husband's sperm is, I'm not getting pregnant. So 40% of the couple, the so-called unexplained infertility, is more frustrating to the couple. My suggestion to them is, it is called unexplored infertility rather than unexplained infertility. The reason is, you can understand much more details with a very high quality trained ultrasound. They can assess the uterus or the living room for the baby is affected with the commonest problems called myoma and adenomyosis. They can assess whether the tubes are blocked and swollen. They can assess the ovaries are in the right place or not, whether the number of egg bags are good or not. You can avoid blood tests to assess her ability to create a baby, such as AMH, which is expensive. The variability within the lab is extremely high. AMH is considered as a fertility test for a woman's ability to create life, or called ovarian reserve. In my opinion, if you can see the ovary properly with an ultrasound scan, you can count 10 follicles or 10 egg bags on each side. There is no role of doing FSH, LH, and AMH. But if you can't see the ovary very well, you need to depend on the second test to assess whether the ovarian energy levels in the ovary, the AMH will be high if the energy levels in the ovary. So I use a simple layman word. There are a number of players in the dressing room, or a number of students in your classroom, or the number of girls in the village to be married is called ovarian reserve test. So that's, so you can substitute ultrasound. Ultrasound is extremely reliable to represent the hormone status of a woman. And same, if they can see the baby food called endometrium very well, you don't even need to do estrogen test. You see the beautiful red carpet to invite the baby to keep it nurtured for 9 months, which is called endometrium, again with an ultrasound in the mid-cycle, which even avoid needing to do any further hysteroscopy and all. So women want to know, are they likely to get pregnant, or are they unlikely to get pregnant even with technology at the earliest possible time? And ultrasound is the leader in that.
So if I could simply put it in one line, I think ultrasound, according to you, for we clinician, is very useful to make a roadmap to treat our couples, find pathways, and also give us predictive modeling. Am I right, Dr. Karnakar?
Absolutely.
So if you're saying that we have...
And if I interrupt you there are people who don't like vaginal scan. We can do abdominal scan, and the virgins, we can even assess fertility in women who never experience if, the virginity is intact. We can do rectal scan, which I introduced even in Middle East for the first time, that any conditions that, vaginal examination becomes unacceptable, you can do rectal scan without any harm, without any damage to their virginity, to get the absolutely same as good as a vaginal scan findings. So that is just I want people to know, how do you examine the ovary perfectly? A lot of people are still doing abdominal scan. I encourage those clinicians, please use vaginal scan or rectal scan, because the gain, the visibility of the number of follicles is crystal clear. You're almost in a touching distance. So I encourage people, rectal or vaginal scan to assess fertility.
So if we look at it, I think we are using an optimal use of technology in the present day when we are doing a one-stop assessment. Again, kind of a little of, inquisition, I think, as a healthcare or even as a patient, your patients would certainly ask you, doctor, what do you think is the best time for me to come for a scan? Because, a one-stop means when you're trying to assess everything, there'll definitely be this question which will pop up in minds of the patient and the clinicians alike. So what do you think is the most suitable phase when the woman should come, or the couple should come to us? Because we can, for the man, there's no issue of the dates. But what about the women when they come? Would you think you look at the dates in her from her periods, or you can call her any particular day?
Yeah, so it's always mid-cycle scan. The reason is that it gives the maximum possible information with minimum number of visits. So you can always see if there is a big follicle, the bride is ready, and the other 19 girls are step back like, the supporting background music to the heroine. So you will see 20 follicles, one of them is the bride. Then she has done the brain communicating, the brain being the leader, the hypothalamus, and the CEO, owner being the hypothalamus, the CEO being the pituitary, and the manager being the ovary. So you can see all of them in one single shot. If the reception is ready, you can see the follicle is ready to pop or it's already popped. The girl is ready to go or it's already left home. You can assess that within a minute. Then the food is ready for the couple when they go. So that is called endometrium that you assessed. If the tube is damaged at that time for any reason, you can see swollen tube like a water bags on either side of the ovary called hydrosalpinges very easily in the mid-cycle. Finally, you can see if there is any unwanted fluid inside, any pathologies inside more strongly because everything, the face looks very big in the mid-cycle because events happen at that time. 5 days later, implantation happens. So everything is set ready. It's almost like reception is ready. The cake is made. You go and assess and see it's worth going through. So mid-cycle, best time.
Okay. So this is a fantastic way of, the analogy that you've been given, I think is amazing. I think this will stay longer in our minds than the theoretical aspects. So having seen women across in India, you work in women in UK and now in the Middle East, do you see any differences in women accepting to a one-stop? Or do you think, yeah, women would be willing, or does it matter, the society or the social norms, do they kind of affect how women would take the doctor is the same. Dr. Makaranti is the same doctor, but do you think women in some parts of the world are more receptive or they're more resistant? Do you see there's a change in the acceptability, and does it matter in our
Yeah, so
management?
developing rapport by clinician with the potential parents is phenomenally paramount. I do free consultations before I see them ever in my clinics. And there is a tendency in NHS UK that there is a mass clinic. 50 couples come for a common meeting. So there's a single fertility consultant talking to 20 to 30 couples. So they all get to know what is the natural conception, what is the deviation from natural conception, what are the simple tests, what are the treatment, what is the success, what is the complications. We give an overview lecture to them. So then individual patients come after that. So there is already informed, well-informed couple coming for mid-cycle as no, loss. Most couple will come for the mid-cycle scan. Now, when I travel to Pakistan, when I travel to Nepal, when I travel to Sri Lanka, the situation is different. The way the people approach in NHS is different, and in Middle East and even in India, some clinics that travel. So we cannot apply one principle to all the women. One shoe doesn't fit all. So clinician has to be relevant and meaningful to the life situation of the couple. So I encourage people, just talk to the couple and see when they can come, what they can come. You may have to see them twice if that's what the life situation warrants or permits. So there is no rigidity. Flexibility and meaningfulness to the couple's life situation is critical. The couple to develop compliance and trust with the treating physician.
That's fantastic. So, the way you presented an answer, that's beautiful. So if we look at infertility, as I say, it's a problem of the couple and there are rising trends. We also understand that there is an increasing demand for IVF, that is in vitro fertilization or test tube babies. If I look at statistics and data, in India in 2020, roughly 2 to 2.5 lakh couples go for IVF or went for IVF in that particular year. And if we look at the CAGR as what the IVF industry sees, which is the compound annual growth rates, I think in the healthcare, this is the highest, climbing industry with the CAGR in India of close to 20%. Phenomenal in any part of the world other than, India, which is showing such a growth. And it's expected that, this industry is going to grow to a volume where 5 to 6 lakh couples would actually be seeking help with IVF or trying to get babies through IVF. Do you think IVF is the panacea for all infertile couples, or do you think yes, there's just a few who will need it? And So that's first part of what I'd ask. And then we go later that, do you think there are some couples who should be alerted? Look, you this. So how would you sort of look at this rising industry? And how do you think is the rising demand, or how do you see this in terms of your practice?
In UK, the system is different. We don't treat people above 39. So if you chose to be mother for whatever reason, you couldn't find Mr. Right, and you suddenly think you want to become parents with Mr. Right, and there is no freebie. And the cost is so prohibitively expensive across the globe. So there are factors, social demographic factors, which cannot be discussed to a details in depth on this podcast. But I will say 75% of the people, even in Australia, who have been declared only IVF can help them, did not proceed with IVF. 75% of a developed country. So the cost and people's opinion about advanced technology is still playing at large. For most people who need, cannot even afford an IVF. So that is one, the cost factor that is eliminating. Second, people's beliefs about it. They think it's unnatural and babies looks like monsters when they have babies with IVF. Still, there is a trend in several countries, for no doubt, and that I come across. They also feel they are no longer fit as a female or a man if they don't conceive naturally. They don't accept the defeat of being a man if a technology has to be used for him to be a father. In many cultures, that is the case. Women helplessly, if she can't survive in the nuclear families, so they go anywhere to any length. But money is a serious limiting factor. But when we scan them, if the ovary is too small, technology cannot help. If the tube is badly damaged, without IVF, they can't pregnant. 100 out of 100 people with a damaged tube, where there is no wedding hall, they have to have the wedding outside their own living room. So the point is, every cause dictates 100% IVF. Some conditions warrant eggs from elsewhere. Some conditions warrant sperm from elsewhere. Some conditions warrant the living room from elsewhere. So we don't generalize. Once we analyze the fertility assessment within 10 minutes, 15 minutes, we know 80 to 90%, this ovary is capable of producing baby with its own genetic material. Or I can even say 99%, that ovary cannot create a baby with its own genetic material because it's too small. There is no student in my classroom. I cannot coach anybody. So the assessment will put them the prognostic red category. Nothing will help, even if they have money, even if there is a technology. On the other hand, if the pathology is small, even just telling, I have given 18 children where, for whatever reason, they could not have intercourse. So I just simply asked husband to provide a sperm sample on the day the girl is ready to be married. And the lady put the sperm inside her body, like you put eye drops when you have an infection in the eye, you just put the drops like a dropper. She put it. 18 children I helped at Cambridge Bone Hall without women having intercourse. So I don't come up with a fixed protocol, which women, what technique I offer for them to become parent and cherish the parenthood.
That's really interesting to hear experiences rather than what we hear from books. So I'm sure people who are hearing this podcast would understand that one size doesn't fit all. It's not that everybody has to go in, because, we do feel that there is a lot of social pressure. And of course, there is a financial drain to the humongous cost that's kind of embedded in this IVF treatment. Not only is time consuming for the couple, but it is also the kind of money, but also the multiples visit that they need. So I would just say that, can you put in that, yes, there are certain conditions, yes, A1, 2, 3, the couple should not wait, should go in for an IVF, or rather women, where I think I should alert them. Look, there's no time spending on simple things like they'd go for, some complementary therapies. Would you kind of tell us or tell the audience, yes, this is the place she should move fast for an IVF treatment rather than sort of wait?
Correct. There are couples who are coming for IVF within 6 months of married life because she's 40-year-old. She knows a lot from Google Doc, saying that, I have Down syndrome risk. I want to rule out abnormal children not to be born from me. I can afford. Simply they walk in, even arrange, they're about to get married. They come and store their eggs. So there's one extreme, well informed with the correct knowledge by their whatever source. in certain countries is very common. They just preserve their fertility when the fertility is genetically more competent and then play with those gametes bit later. So that is one extreme. The other extreme is that they only have 1% chance of pregnancy. They're willing to try 10 IVFs because they can afford and they have means of doing it. Whereas majority of the couple, usually they come in the reproductive age group. So luckily, we are able to help. If 100 people are walking to my clinic, 20% need IVF, maybe 10 to 20% of, or up to 30, I do IUI, which is just helping boy and girl get close together in the right time. So it's called simple assistance. Or we just talk to the ovary in a more polite way because ovary sometimes is behaving like a teenager. They argue with their own parents. That's called polycystic ovary. So they just have a bit of argument. The teachers and students argue, family members argue, the parents argue with the teenage daughter. So that is called polycystic ovary. 60% of the people who are in a rice eating or a wheat flour eating countries, the reason for their infertility is that lack of communication between the brain and the ovary. So we just put some peacemakers there, we call them, ovulation induction, control, ovarian stimulation. It doesn't matter. We make more beautiful talking, more compassionate talking to the ovary, and we encourage ovary to behave like nature. So these are the simplest ways to approach different aspects. Whereas if the tubes are damaged, which is the wedding hall is blocked, 100 out of 100 they have to go for the replacement of tube, that is called test tube. That's all.
That's brilliant. I know how you've given such vivid, such interesting examples to make this story so interesting. So I think I'll just go back to how we started on stress, and we started that there is a rising trend in infertility, and perhaps the backdrop of our changing social fabric, our social lifestyles are changing. Do you think when you meet couples at One Stop Clinic and you have time, do you think you talk of measures or means of telling them to alleviate their stress? Or do you think there is a place where spirituality would come? It's the mindfulness, or, it's like time to give them that kind of a guidance as well, or handholding on that side?
I'm fortunate enough to spend time with Upanishads for nearly 30 years. In All India Institute, there is a section called Occult Sciences just behind the administration in the Dikshit Library. All the best scientists in the world wrote about how to be friendly with the mind. Those people who are friendly with the mind, they're in tune with it. That's called Bharata, Bhava, Raga, Tala. We are in tune with your body, with your emotion, with your energy levels. And then your endocrine system perfectly works in an order. These are the 98% of people producing kids without seeing any doctors. I meant to say 98% of the children are born without seeing any doctor, without any pill, without IUI, without IVF, because there is a proper tuning of hypothalamus, pituitary, ovary, uterus, because they are in harmony with body, mind, emotion, and energy. And that's our ancestors. So people who follow what our grandparents ate, the way they lived, the way they spoke to each other, the way they worked in the sun, these are the people, and exemplary produce 6 to 10 children per family that all of us, every culture fondly know. If they were not healthy, we won't be here today. So therefore, if you can adapt what your grandparents did it, then that is the first point. Eat what they ate, talk what they did, sleep the way they slept, be the way they were. That is the best care that I can give. Then comes individualized care. A lot of women don't talk in front of a husband because if they're not having intercourse, they don't tell it to a strange person in a clinic in a 20-minute, where the clinic also has antenatal clinic. So I find, so we are not ready to address the psychological remit of a couple in each and every case. We treat them as 40 people, 50 people in a 1 hour when you have your phone ongoing and you have an emergency waiting. I'm product of All India Institute. There were about 40, 50 in every residence room in the 3rd floor. I could not even see. I can give an example. There is a man who walked like a female. It's called testicular feminization syndrome, married to another man. They came to become parents, and I have to tell them I'm going to remove his testes. It's a shocking thing to break the bad news, but I have to do it. So those doctors who are listening today, please approach all of them with the same way, that there could be a genetic reason, there could be a chromosome reason, there could be hormone reason, there could be psychosexual reason, and organic tumor reasons. So please approach all the hardware reasons for infertility, all the software reasons for infertility. Once you diagnose, 90% of therapy depends on diligence and accuracy of diagnosis. That needs patience. That needs empathy to the infertile couple. That warrants time. That needs passion to what you do. That needs love in what you're doing. And these are the people who are giving highest quality infertility care. It doesn't mean you give child to every couple who come, but you give the explanation, accurate explanation. The science cannot help because your living room and the carpet or the food for the baby is damaged 99%. You can create baby through IVF. There is no place for it to grow. So creating life is no solution when there is no place for life to grow. So people are not giving the complete approach called A, B, C. A means the women's ability to or man's ability to create a healthy baby. B means women's ability to accommodate and feed a baby. C means the compatibility between man and women or the guest and the host. So ABC model approaches to the infertility or treatment failure or miscarriages. So that's what we do. British Medical Journal introduced the concept of ABC of headache, ABCD of pain, ABCD of epilepsy, ABCD of infertility. So I grew up in that model. Wherever I teach, I simply say, let me understand your ability to create a competent baby is in the green or amber or red with a blood test and a scan. Let me understand your ability to accommodate and feed a baby is in the green zone, amber zone, red zone. Let me understand, there is no Sasural and Bahu arguments. There's no guest and host fights. And that is the 1/3 of the failures of IVF is because there is no respect to the host. So the tourist and the host are not good to each other.
I think you've brilliantly put it. It's just not biology. It's not just the science. It's the art of, kind of understanding your patient. And I think that's what is making you such a brilliant clinician. No wonder you've touched so many couples and you've touched the hearts of so many couples and helped them create babies. So I know that this has been quite a bit of information both to our, viewers as patients who are listening to us as doctors. And I think what is an approach is be holistic. Look to them with empathy, give them the time because they need just not your scientific knowledge. They just don't need the approach that you give. I think they need a holistic approach where you give them enough time to understand. Now, as we're coming close to our, this Gyan Pravah, and I do understand if we can go, we can flow in the Pravah and we can keep going for hours together. What would be your approach or kind of some advice, and I would say advice to the youngsters who are sort of dwelling in this field of infertility, reproductive medicine and infertility, because, there is a lure for people to sort of get attracted to this subspecialty. What would be your advice to the youngsters who are taking up to this specialty with so much vigor? I mean, where do you see future 10 years from now in reproductive medicine with so many people getting attracted to take this as a subspecialty?
Yeah, I met IFS conference 1,600 or between 1460 to 500. That's one conference. I didn't go to the ISAR last week. I might have met another lot. So you're talking about just 2 meetings in a year where you got around 38,000 gynecologists. And the attraction here there is no night duties here. There is no bloody surgeries and there is no major complications. In fact, the death from any infertility treatment can never be more than 1 in a million occurrence. So it is one of the safest branch of medicine. The training is fastest. And so I would say more people who want to have a light professional life with a decent income, they're going to embrace no matter what, whether we encourage or discourage. So that is a fact that is going to evolve. That is one. Second, giving parenthood, because we love our parents. Without our mother and father's love, we don't be what we are today. So to give that opportunity for those, people with a disadvantage is a beautiful experience. Honestly, you feel so beautiful to go to sleep that day when you have a positive pregnancy test, whether it is a mild help, moderate help, or severe help. Equally, conscientious people, it hurts that you did everything possible. She's having 10th miscarriage, 10th IVF failure in front of you. I see this every day because the more pathology that it is, the less likely you will succeed and the less likely you can justify even to say, why did I work for 30 years in major universities? I can't even help this couple miscarrying 10th time in front of me, failing 10th IVF also in front of me. But the level-headedness of the doctor, the integrity, the physical health and mental health and emotional health of the doctor easily percolates into your patient. Say if you are a fit doctor, as I'm telling a polycystic ovary women to lose weight just brashly in a brush doesn't work. But if you look fit, I have patients whom go with me to my gym. Husband, wife, I take them to my gym because once they connect with you, we have a habit of, following our mentors or our idols. Once they feel by losing weight, the doctor is going to help me to become parents, most people become compliant. On the other hand, WHO data will show 50% of the people who are on polycystic ovary never adhere to single prescription that you give. They are doing window shopping for the next pill, next insulin sensitizer. They want to avoid being told to lose weight to increase the parenthood. So I'm just giving an example where you're disconnecting, and that should be prevented by any sensitive doctor, any conscientious doctor. Rapo, rapo, rapo. It works wonders.
I totally agree, and I think I can share a bit of my experience when you said the rapport. No, I don't think I am as experienced because I've worked only in India. But when you sit and talk to your patients, give them the confidence and the hope, I think they come really forward. And as in weight loss, we have an ongoing trial called the IPOS trial at 5 centers. And we've seen that of the couples that we see, we can help, and we've helped in the 2 years of our working. It's a 5-year project. We're looking at 25% of our couples from all corners of India, north, south, east, west, have had babies without taking a pill, without taking letrozole, without taking any medicines or injections. It's just the weight loss. And we totally iterate that how you navigate their journeys is very important. Just one bit I would say that before we wind up, would be your one liner or a message that you would like to give to your patients who have lost hope? Because yes, as you rightly said, we're not gods, we're not playing gods, but somewhere they still come back to, even after the 10th IVF failure, they'll still come back to Dr. Karnakar and say, doctor, can we try again? And what would be your best advice to them?
It's the best question you asked, Dr. Nina, Professor Nina, today. The reason is there are, I would say, 30% of the implantation failure are due to difficult embryo transfer done by the operator. 30% of failure. So therefore, by doing your job at the highest quality, you can avoid treatment failures. I'm just giving one example, which is 30%, which is huge. Second, not even doing IVF when the uterus is not good, you will never fail because you should have never done in the first place. So giving child should be your target, not just producing follicles by giving tablets. People are thinking, so you're not setting. Growing eggs is not final goal. Creating an embryo and giving a biochemical pregnancy should not be your goal. If you think she's your daughter, she's your sister, you will never falter. You will give the top 3 centers best miscarriage care or implantation failure care or the genuine success rate. If I say it's going to be 5% success, 95% guaranteed failure, they cry in front of you, but they salute you when they leave your consultation room. So this is the beauty of practicing medicine. Vaidya Narayano Hari.
I think rightly said. I think it's your integrity which matters. And I think
Absolutely.
that's what you...
Qualification doesn't matter. Paperwork, research experiences, drugs, the pills, and your qualifications. No, integrity.
I think we've had a brilliant time, and I just didn't realize that we've almost spent 15 minutes talking on this podcast. So I think this would be one of the first that I'm doing, and I think I really look forward on every 10th of this month, of the coming of 10th of every month in the coming year for yet 10 more podcasts. So thank you so very much, Dr. Karnakar, for being with us. Absolutely, and I'm sure I absolutely enjoyed, and I'm very sure the audience who's going to watch this when it goes on whichever channel or the Fogsi site would also find it a treat. And for our patients, for our doctors, for our colleagues, thank you very much for being such a wonderful guest and such a wonderful speaker and enlightening us. Thank you so much, Dr. Karnakar.
If I can take 30 seconds. CouplesToParents.com is a free website people can access. There are frequently asked questions, and I've given this animation sort of explanation in absolutely layman language so that anybody, they understand the reproductive medicine in the easiest possible way. So couplesToParents.com is a website people can access and learn how things work and why things fail, why the nature doesn't work, and where the doctors can help, where the doctors cannot help.
So thank you very much. So to all our viewers, keep watching these podcasts. And for me, I think the 10th of every month, I'll bring you another surprise with yet another good speaker on our podcast. Thank you very much.
Thank you so much, audience.
Thank you.